I want you all today to meet Maria. Maria is a 62-year-old Hispanic, Spanish-speaking female living in Santa Ana. She works 2 jobs. Her first job is 8 to 5, Monday through Friday. And then she works a second job on the weekends, half a day. Maria does not own a car, and she has to take the bus to work, which means she leaves her home at 7 a.m. in the morning and does not get back till 6 p.m. In the last 18 months, Maria has had 3 emergency room visits, not because she had any acute health issues, but because she ran out of her prescriptions. Maria has type 2 diabetes and high blood pressure, so she's on prescriptions for both. Each of these emergency room visits was because Maria could not seek health care that suited her 8 to 5 lifestyle. Each emergency room visit, by the way, is about $4,000 to $5,000. You can do the math. We wonder why healthcare is so expensive in this country. We live in one of the most advanced countries in the world, and I might add, one of the most affluent counties in this state. And yet, the story of Maria is repeated day after day, month after month, in thousands of patients. As a primary care doctor myself for the last 30 years, and as someone responsible for clinical informatics and AI deployment for a large academic health system, this is the problem that keeps me up at night. How do we solve health disparities for patients like Maria? How do we meet them where they want to be? Now, with the advent of AI, I am, for the first time, very optimistic that we have opportunities to bridge this gap. Let's examine what is wrong with the current system today. The barriers Maria faces are too many. 1, language. She's Spanish-speaking. Most healthcare systems today cater to the English-speaking, whether it be navigation of the website, or calling for an appointment, or even getting into the healthcare system, your front door. It's all in English. Even if there is Spanish translation, it is not in a manner that is patient-friendly. Her second barrier is no knowledge of digital literacy. Maria does own a smartphone. She does not have a computer, and she has very spotted internet access. Her smartphone she uses predominantly just to make phone calls and SMS messaging. Ask her to download an app, and she's completely lost. Her last doctor visit, a support staff there helped her download the patient portal. She did succeed, and the portal is in Spanish. However, the next time when she tried to navigate it on her own, she failed miserably. She had no idea how to do it, so she gave up. Her third barrier is the healthcare system not having its doors open when she wants it, and not in a manner that she wants. She has transportation barriers. She rides a bus. How is she supposed to make it to her appointments, which are only available from 8 to 5? No wonder she defaults on her prescriptions. When she calls her doctor's office, they tell her that if she has not had a doctor visit in a year or lab work in a year, they will not refill her prescriptions. And of course, she ends up in the emergency room. Fourth and most important barrier. In all this learned experience that Maria has had, she has developed an inherent distrust of the healthcare system because she has been sidelined, marginalized, and dismissed so many times. The last time she was in the emergency room, she recalls a staff there telling her, "Why are you taking up room here? This is meant for acute problems." She felt really dismissed. So when my team and I got together when we were implementing AI-driven systems, we said, if we design systems that work for Maria, they will work for everyone else. It is not that we are sidelining the privileged. We are accommodating more people in this ecosystem. We called it the Maria First Design Principle. Here's what we created. Our first task, a simple AI chatbot that is based on SMS text messaging. It is voice-based, so no typing needed. It is language agnostic. And it is as simple as you opening your phone, speaking into it, and it knows what to do. Let me show you how it's helping Maria. She comes back at 6 p.m., rests for a little bit, she's tired from work, eats her supper, and 2 hours later checks her blood sugar. It is 185. She doesn't know what this means. She simply speaks into her phone and says, blood sugar 185. She says this in Spanish. The agent doesn't care what language she is using. The agent has algorithms behind it and smart systems that we have taught it. It talks back to her in Spanish and advises her whether she should take her routine medication as usual or increase the dose based on the algorithm. Or it could advise her to do something different, like, seek healthcare if the sugar is really high. What it also does is ask follow-up questions, like, what did you eat for supper? Maria rattles off the menu she had. And then the bot is smart enough to tell her, ooh, that ingredient in your meal is probably what caused that little spike in your blood sugar. Isn't that smart? Now Maria knows exactly what to avoid at her next meal. So she's empowered to take care of her health. That is the power of AI. The next thing we did was look at predictive analytics. Using a large data set of patients like Maria, we enabled cognitive computing models, which use machine learning. And we studied these models over time. It was not a once-in-time deployment, and we are still studying these models. With that, we created a lot of predictive signals. Signals like likelihood to no-show at an appointment, likelihood to show up at the emergency room, likelihood to run out of prescription, likelihood to deteriorate in terms of her health needs. Now, what do these signals do? They are alerts in the electronic health record. We have dashboards galore around this. But none of this is meaningful to Maria. What is she going to do with these signals? This is where we started thinking, what if we connected these signals to actual community health resources that are trusted by Maria? So that's where we went next. We connected these signals and made them available to a community benefit organization we work with. Now they know when Maria is likelihood to seek emergency room care, or likelihood to need an appointment, or likelihood to run out of prescriptions. They proactively call her and say, is it okay if we just deliver your prescriptions to your doorstep? Or can we help you set up a lab appointment or arrange transportation for your upcoming appointment? The next step we did was, even when Maria comes in for her appointment, it is in a manner that she wants. It is not just an 8 to 5 front door. It is now a digital front door where she can choose appointments via telehealth or in person. Even when she sees her doctor for her in-person appointment, it is very different now. Gone are the days when the doctor is facing the wall, facing the computer, just typing away, sidelining Maria, no eye contact. Her doctor speaks English, there's an interpreter in the room, and there's Maria. Maria often wondered, is the interpreter even communicating to the doctor the same things that I am saying? She was never sure about this. Now we introduced ambient technology into the exam room. What it does is seamlessly record the entire conversation, irrespective of how many people are in the room. The end result, the physician is facing the patient for the first time, making eye contact. Maria is feeling heard and recognized. She now realizes that the physician is paying attention to her. At the end of that visit, a note is created for the doctor in English, in medical English, because that is needed for the EHR documentation, for regulatory and billing and other purposes. But here's the beauty of it. A copy of the note is created in Spanish at Maria's reading level that she can take with. Not only is there a note created in Spanish for her, there is also instructions captured from that conversation that are created as part of the note. So when she leaves the exam room, she knows exactly what she needs to do next. She had a very bad experience with something like this, where when she was leaving the doctor's office, she was handed a pamphlet when she asked about what diet she should be taking, and it was in Spanish, but it was about the Mediterranean diet. She read the ingredients, none were familiar to her, so she tossed it in the garbage can on her way out. Now, when she gets this document using ambient technology, it is very relevant to her care. And this adds to her empowerment. And while we did all this, we did not take out the human connection. Human connection is very important in healthcare. When you are sick, you want to hold a hand, not a robot. So through all of this design, at any point if the algorithm or the agent or the bot is getting stuck, we escalate it to a human because that we know is important. So what is the outcome of all of this? When we studied the results and the impact on patients like Maria, we saw improved patient experience. And we said, what if we ground ourselves in these rules and always when we are designing these systems, we keep these things in mind? So here is our design principles. 1, language agnostic tools. We have 12 languages today with more to come. The second thing we did was making sure it's multimodal healthcare, where we meet the patient where they are, not the other way around. The third design principle is no assumptions of digital literacy. We keep it simple. If it works for Maria, it'll work for everyone else. Fourth, and very important principle was avoid bias. How we do this? A large amount of healthcare data is biased today, and bias is pervasive. These AI symptoms learn from data. If your data is biased, your AI is going to be biased. So we said we will never use any off-the-cuff AI system without actually examining it in our walls, feeding it our data. And not just our data of patients like Maria, data of patients who are living in our community like Maria. They may not be seeking care within our walls, but they represent the larger population of patients we might be taking care of. And that's important. And then the last but not the least, the very important principle of what we call human scaffolding. We would not let these AI systems become autonomous at any point without a human in the loop. So we don't let the AI drive itself. The human connection is always preserved. So what is the outcome of all this? And where is Maria today? Maria is still living in Santa Ana. She still holds 2 jobs, and she still takes the bus to work. But here is the difference. Her hemoglobin A1C, which is a test for diabetes, is showing improvement. She is, for the first time, feeling seen and heard and empowered. Her trust in the healthcare system is restored. She also is having her needs met within her community, which is important. And beyond all this, Maria has related this new way of getting care to her coworkers, her community, her neighbors, and her family. And now they are intrigued. Her stepdaughter has signed up for a similar healthcare delivery model and is very pleased with it. Gone are the days of struggle with patient portals and things like that, which she could never navigate. So here is what we have learned through this journey. AI is not neutral. AI can propagate discrepancies or it can mitigate them. Humans implement AI, so it's on us to pay attention to these things. It's also rapidly rising and going to be pervasive in healthcare. So we need to start paying attention to these things now. And finally, I'll say that the age of AI in healthcare is here. It's up to us to make it the age of equity as well. Thank you.